This is case discussion for best solution. I am Kim Se-jin, moderator of this program. And today we have again three clinical masters with us, Dr. Kim Kyung-won, Dr. Park Jong-yeon, and Professor Yang Seung-min. Thank you for joining us. So let's see today's case. Palatal roots has periodontal disease up to apex side and it's left like that for a long time. So only palatal bone is falling short. It's been 2 months since extraction, but still palatal bone is falling short. So we need bone grafting, but I've never done palatal side bone grafting. What should I do? So doctors, what do you think? Maybe Professor Yang, you can go first. Actually, I do believe it's just a general GBR case, be it on the palatal side or not. I don't think it's an important issue. Rather, in managing flaps, palatal side might be more favorable. But I believe that the issue is about whether to do graft or not. Now, in this situation, 5 millimeters would, of course, on the palatal sides, implant will be exposed. So how to manage that? I think that is maybe gist of the question. But again, I think you can have same approach as a general GBR. For me, I also have similar thoughts as Professor Yang. I think the case was asked because palatal side GBR bone grafting, it doesn't have much experience, so you might think it's different from the buccal approach. But I believe this must be easier. Of course, palatal mucosa is thick, so their glandular tissue or soft tissue, if it's packed with that, then treating that might be a challenge. So maybe that was the issue. Yes, that could be. So again, if you're joining us, then let us know your opinion. If you have any good comments or should to share your comments, please post them on our chatting box. So let's see how these doctors treated similar cases. Dr. Kim Kyung-won, you can go first. Yes, as I said before, for me, looking at this case, I did not believe it's such a challenging case. So I tried to find something similar, but could not really because maybe I thought this was not such a tricky case, so I didn't read records. So this is a recent case, and I think it's very similar. It's April of this year, and for this patient, it already has implant on the front, and 16 and 17 are missing in the opposing teeth. It's only number 6 is available. So patient did not want 2 implants, only wanted 1 implant, maybe due to financial reasons. So as you can see in the initial visit, we took the panorama photo. And on the CT side, it's very similar to the case in question. So there's a lot of bone missing on the palatal side. So again, we took the CT with 1 guide and planned with the 1 guide, and the buccal side there was some remaining bone. But when you place implant, the palatal side inevitably would there be exposure. So their side we use 1 guide and did GBR together. This is surgery video. So incision, we slightly leaned toward a palate. We are going to use 1 guide, but we did a bit of incision, and based that 1 guide was used and 1 guide drilling was done, and then placed implant. So drilling is finished and implant is being placed. And as far as you know, diameter is 5.0, 10 millimeter implant TS type. And after placing it, things we opened flap, palata was exposed. In editing this video, I did not put where I removed all the granular tissue, but I removed all the granular tissue to secure space. And palata mucosa was not fully healed for this patient, so we used xenografting here. And again, collagen membrane was used to cover it. So on the palatal side, in some cases, not using membrane, they opt for that too. But here, to secure space, I opted for xenografts, and again, collagen membrane covering with such membrane in bone regeneration, I think was favorable, so I did that. So as you can see, this is a post-op panorama photo. So on the panorama side, nothing particular, but on the CT side, as you can see, on the palatal side where there's a defect, we did for sure bone grafting. So if you approach like that, so on the palatal side, for sure, if you do bone grafting, then compared to buccal side, actually it's easier because palatal mucosa is thicker and it's not really moving. So I think the result will be more favorable. So it's not such a tricky or challenging case. So about 2.5 months later, panorama photo. So, of course, you need more data than this, but I don't have prosthesis photos. So, sorry for that. So that is really recent case. Thank you very much. Now, Professor Yang, please, your comment. For me, as I said in the beginning, I think it's just a general GBR case that I want to talk about. So number 26, mastication was not really, the patient said, comfortable. So when you open plate in the palatal, there was something strange. So there was root fracture. So on the palatal side, if you have such a force loading, this was woman's, female patient, but mastication was really strong. So there was a fracture, and after healing, it's very similar to previous case. So on the palatal side, there is no bone, and as you can see, 26 to place implant. If you open it up on the palatal side, there is a slope. So it's very similar to the CT photo. So there are different ways of going roundabout. You could do sinus lifting. So, place it deep and or on the fit it to the buccal plate. So you could do the top side GBR. So I just did alignment, and you see the thread has been exposed a lot. So I wanted to use my typical process, but on the palatal side, the flap is thick, and if you even thin there, because of the weight on the part I want, the graft I thought would not be maintained. So what I did was I used something that was rigid. So titanium mesh was used to create some form. So at the time I thought autobond was a must. So first, on the exposed surface, I used autobond, and then I did xenografting, and for contouring, titanic mesh membrane was used. So there, flap closure could not be done very for certain. So the thinning CT was taken out and was covered for primary corrosion. So after CT graft, the biggest problem is in healing. This happens. So it really swells. But despite that, there is exposure. So in titanic mesh, you have to manage it very well. And there is certainly limitations. So you have to gain experience in that area. And nowadays, non-submerged approach is also available. So you could also consider that. So we remove that in the exposed area. As you can see, the plaque is there. So on the mesh, it doesn't really look good. So we healed, and then now it was healed, so we delivered final prosthesis, and after 1 month later, patient said there was pain, so we removed it. And so osseo integration was not really done. So inside, we removed everything, healed, and placed it again. So osseointegration, there is a failure because of the biting force. Maybe from the beginning, there was a weak osseointegration. So we measured everything, and torque with the 35 Newton, there was not a problem. So I did not understand why there was fracture. So next time I thought I need to do more, better and really thoroughly. So stacked it up, but still not fully formed. So, but thread is not that much exposed. And again, autogenous bone was used, and genografting was done, and then resorbable membrane was used for contouring, and again submerged. And after submerged, exposed area was removed, and then second surgery. After that, prosthesis was delivered, and for 6 years, no problems, using it very well. So the initial failure, I thought about the reason. I think it's because the osseointegration was not fully done. So because of that. But after osseointegration was fully done, there has been no problem. Now, even on the palatal side, to fit the contouring, titanic mesh, that type of membrane, yes, you could use, but I think the best way is whatever you're familiar with. Using resorbed membrane was used and submerged. Now, surgery is advancing, so now we can even use non-submerged types. So very similar case on the palatal side, there was a perio and there was a big bone defect. So I wanted to do surgery, but the defect was too severe, so we took the tooth out, and you can see the defect there on the left bottom palatal side. There is a defect, and after healing on the palatal side for sure, similar to the case in question, it will be healed. So when you take the CT picture again compared to buccal palatal side, there is a bit missing. So when you place implant, there's not much of exposure, but for contouring around implant, we do genografting, and based on that, covered with membrane. And here we didn't submerge, we did non-submerge GBR, and so it's still in good use, and it's not being followed up and not coming back again. But I think the patient is not coming back again because there is no problem, so we don't have any more data. But when we did non-submerged approach, how the healing happens is on the crestal side. There's a bit of exposure, but there is a healing. So what we did is not on the crest side, it was palatal side. So I think it would not impact that area. So we again I said final prosthesis was delivered. So the case in question, whether to do palatal side GBR or not. But I think again that's very similar to buccal GBR approach, and whether it's submerged or non-submerged, again whatever is comfortable to you. And I always emphasize whatever is familiar in your hands will give you the best success and would give you most predictable results. Thank you. Thank you. I do have a question. For me, when I do GBR, still I do submerged. But as you have shown, transmucosa or non-submerged approach is also happening quite a lot these days. So in your opinion, if you do non-submerged approach, it will be not so favorable for bone formation. What do you think? I think in terms of quality, yes, that's what you could think. But on a long-term basis, because sometimes when you do implant, next day we open it up. So I didn't, bring those cases but you can see it's quite holding up very well. So existing conventions, breaking out of it took a bit time for me too. But these days I also do quite non-submerged approach too. So when do we do non-submerged? When there's horizontal defect. If it's vertical defect, then yes, it's more favorable to go with submerged. But if it's horizontal defect, dehiscence or penetration, then that type of approach would not have a big issue, and on long-term basis, again, not much of a issue. Yes, transmucosal TBR is something I should do. Yes, please try. Then lastly, Dr. Bach, please share your case. Now, if I have also question, I will ask these two masters. Now, on the palatal side, if there's a bone loss, then let's see, when you open flap after situation after 6 weeks on the palate side, I do not believe it will heal or feel naturally. So this is my favorite approach. So for 6 to 8 weeks, I just do bone graft first. If the cavity is not going to be healed very well, then I do bone grafting first. And then after 3 to 4 months, then always there is always situation more favorable, so I can do implant. So, but my question is this: implant and then doing bone graft, or doing bone graft first, would there be any quality difference? What I think is, if there's no implant, then there's a more supply coming from cancellous bone. So I think it would be easier and have a more favorable result. What do you think? Well, actually, it's about simultaneous GBR or staged GBR. I think that is the question, right? If you see the literature, clinical result-wise, there is no difference. But as you said, what you said is requires histological judgment. So from that side, I think staged approach, they say, is a bit favorable, but again, no difference in the literature in terms of clinical result. Then you would place implant there and do palatal bone graft. Yes, the vertical side, buccal and palatal, you have slopes. So in my case, as I said, to go around about it, place it deep, or if you align it, then you do GBR. Then volume of vertical, how would you control it? 2 or 3 millimeters, literature says if you do simultaneous approach, there will be no problem. So buccal slope and palatal slope, 5 to 6 millimeters difference, then in that case, if I had to place implant, I would submerge it. Otherwise, I would do non-submerged. Actually, recently, the implant that we use have had a lot of good surface treatments. So it's not machined surface of the past. So recently, I also do simultaneously do implant placement as well as GBR together. So for this case, what I want to, say is that grafted bone, then compared to host bone, it's not as strong or not as good in terms of bone quality. So the graft could lean toward bones if you aren't careful. So you have to be really careful. So pushing toward the bone graft this side, and you do under drilling, then placement could be too palatal side. So you have to be careful again. So because we are careful, the hole could be on the center, and the final prosthesis was delivered. After 9 months, CT was taken. So on the grafted, rather than leaning toward grafted bone, given that buccal bone is a bit not that much, then osseointegration more on the host bone is what I prefer. So again, placing on where you have a good center is important. So again, graft is important, but more than that, how to use the residual bone is more important. Similar case here. So extraction was done too late. So there was a lot of problems. So after extraction, waited for 2 months. So I think staged approach is easier for me on the palatal side. So here, all the thinning was done on the palatal side, grafting, and then waited again. I think there's a lot of good osseointegration. Then again, there was that problem I talked about. Now, grafted bone is rather weak. So if you don't think thoroughly, drill, then push it more on the graft side or palatal side. You have to be careful. So there was hole on the palatal side, and final prosthesis was delivered like this. And after 18 months, panorama photo, and because it's panorama, you cannot make exact judgment, but maintenance was okay. And then residual bone on the buccal side can be used. This is a good situation, right? After extraction, waited, even 5 months again, but bones was not formed well. But on the buccal side bone, he had a lot of good bones. Without so palatal bones, you could do implant placement. So placed more on the buccal, leaning buccal side. So implant could be on the inside the bone and using maxillar liners. So we did the grafting, and angled abutment was used. Of the small abutment, angled was chosen, and gingiva height is 7 millimeters. So as Professor Yang said, placing it deep, use maxillar liners, and going about the palatal exposure, what was missing on the palatal side, we managed it. So it's not all for all people, but there are sometimes, you have easy case because there is buccal residual bones that was quite good. So angled abutment, some people do not want to use it, but I think simple is the best and it's most predictable. Another case, 12 weeks we waited, but tooth had to be extracted and there's not much residual. So you have to really observe carefully. I think you being able to use residual bone is more important than doing grafting. So again, bone is missing. But if you really thoroughly look for it, there is a bit of bone remain on the mesial side. So you have to catch that. So if you do thorough analysis and look at the pictures very thoroughly, even if it's an ideal position, there are some bones. So we leaned toward that, and other defect area we did bone grafting. But for this patient, implant fixtures was surrounded mostly by the host bone. So buccal bone that was remaining, we were able to find it, and the palatal bone is linked to the implant, and there was a bit of exposure on the distal side. So bone grafting is just a support. Host bone, you can get a lot of osseointegration. Bone grafting was just a supporting function. So when we did first bone grafting, I didn't fill it up thoroughly, but after the lymphadenal prosthesis, we took the CT, and bone formation, I believe, was quite good. Of course, it's leaning toward buccal side on the mesial side, but still, it's not leaning toward the grafted bone, but residual bone was used on the max, and grafted bone was just a supporting function. And number 17 was missing, and placed another implant there as a single implant restoration. So beginning it was kind of dire situation, but through thorough analysis, I found that there were still things that you could use. And here I would not do ridge splitting today, but I did it at that time, and because of that, palatal bone was fractured. And what you can do here is you don't have, buccal bone is fractured, I would have really shocked, but not if it's in this area. So you make the granule bones and then put that with, other bones, and did bone grafting. And after time, very clean, and only 4 millimeters of bone was grown to 7 to 8 millimeters. So now it's becoming a simple case. So bone formation on the palatal side, I believe, is easier, and this result can be obtained because autogenous bones was used and membranes was used. So SS implant was placed very comfortably, and final prosthesis was delivered. And this is panorama picture afterwards. Now, on today's case, let me answer the questions. If this is my question, not what was asked, 2 or 3 threads being exposed in placing implant. If the depth is sufficient, I think it's okay. And if you do implant placement and bone grafting together, if the defect type is and defect form is matching, then no problem. If creating form where the bone can be regenerated favorably, that is key. So palatal thinning, as two doctors said, is a must. And the easiest approach, in my opinion, rather doing simultaneously, for me, bone grafting and then placing implant, for me was easier. So let me also show this. Now, here, securing space is key. And if there's not much bone, then granular tissue or soft tissue is there. So cutting soft tissue to secure space is important. So if you put bone and weight, then I think palatal bone regeneration is easy. The important thing is create environment favorable for bone regeneration. Of course, you could use titanium mesh, but on the palatal side flap, it's not much moving. So even with flap thinning, it can be very helpful. So that is the key point. Palatal flap thinning to secure space is what I want to emphasize. Now I have a question, so I prepared a case to ask questions to these two doctors. So very similar to the today's case, but if you have 2 or 3 threads exposed and do not do bone grafting, what would happen? So another of my case, here the tooth was extracted too late, and sufficient weight thing was done and placed implant, but on the palatal side, bone was not much there. So it's easy if you expose 2 or 3 threads and do bone grafting. Then here you don't even have to open flap, right? What would you do? I always say that you have to have your own principles, in my opinion. So depending on your clinical experience, that principle might be different. So that would determine success or failure implant? I do not think so. But why you have to have principles? Because if you have principles, it becomes easy and it gives you long-term predictability. So here I would do GBR. Of course, there would be no problem even if you don't do GBRs, because clinically, as I said, in the literature, they say there's no difference. But implant surface side, I do not want it exposed outside the implant. So assuming that there will be problem later on, it would be really not good. So implants, if you look at the structure, abutment on top of the implant fixture, and the abutment is there is mucosal sealing. So CT attachment and epithelial attachment is there. And there, if it becomes bad, peri-implant mucositis happens, then if it's exposed there, then it becomes very hard to control. So for me, if possible, I would bone exposure. So implant fixture exposing outside of bone, I want to minimize it as possible. So again, that is important for me. 2 or 3 thread might be okay, but 2 or 3 exposure, I would do it. So my principle there is implant exposing outside of bone, I will minimize it as possible. That's my surgery principle. So I will do that to abide by that principle. So thank you. In my opinion also, I think Dr. Park, you asked this question because if it's buccal side, then of course you would have done GBR. But because it's palatal side, you might think, how about not doing it? So basically, I am in agreement to Professor Yang. It's better to cover it up than exposing it. But if palatal side bone grafting is burdensome, and if you have different opinion, then in that case, rather implant type would be SS or tissue level implant might be better. That would be my opinions, especially if it's a single implant, then internal connection type, TS type bone grafting would be principal because if it's inside the bone housing, then the implant tearing could be avoided. But without bone grafting, then implant type, tissue level SS type, I believe might be better. But basically, if it's a TS, I would do bone grafting. So here, it's a number 6 position. That means on the maxillary side, there could be problems. So in that case, I think the question is whether to do graft GBR or whether to do sinus graft, right? So for me, as I said before, if it's TS implant, then bone crest level 1 millimeter going deep is what you are told. So in that case, 1 millimeter deep, and then do sinus graft. So which surgery is more comfortable for you? Some say sinus grafting, or some might have different thing that's more comfortable. So whatever is more comfortable, again, as I said, you have to have your own principle, justification for doing that. That is the most important. And there are many videos on Dano's site. And if you just look at those video clips, you can find your own principles and justifications. So abiding by that is the most important thing. So I think I would do sinus grafting. I do also agree there because basically, rather than GBR, sinus bone grafting, I think is more predictable. And also, and when you try to copy other people, it's reproducible. So to have similar result, sinus rather than GBR is easier to obtain better results. So on that point, I do agree. So let me show you what I did. I also did bone grafting, but healing side H is about 6. So marginal gingiva, I put it about 5 millimeter in depth, but the thread to be fully closed, it needs to go deeper by 2 millimeters. But I thought that was too deep, so I did both. So final prosthesis was delivered and X-ray was taken, and after everything was complete, I saw it again. And I thought, as Professor Yang said, you can actually even go deeper. Initially, I thought the depth was sufficient, should not go further. But after delivering final prosthesis, like this, maybe going deeper on the maxillar sinus abutment emergence profile might have been better. So through this case, what I want to say, I again use residual bone as much as possible. So putting on the center, it's not I put it on the buccal side because I did something wrong. I put it intentionally buccal side because I wanted to residual bone as much as possible. So final prosthesis was completed like this. Now, Dr. Park's principle, in my opinion, is use residual bone as much as possible. I think that's a very good principle because that would give you more stability and there will be not much of a change. But whether it's using more of the palatal bone or on the buccal bone more, but in this case, using buccal bone more, right? That's this case. But the risk here is that now, if you see contour there, buccal contour is a bit low. So that one, bone, well, it's not exposed, but still, contour is not that good. So rather than that causing problem later on, but if that situation, the buccal side, there is a bit sufficient bone, that volume is sufficient. So how stable it is? On that question, on the long term, I believe there's half and half chance. 5 to 6 years later, yes, there's a high chance there's be no problem. But if the oral hygiene is bad, and this case, it's a bit different from my case because I have a lot of perio bad cases. And in many cases that there's a lot of recessions. So for this case, perio could go bad, but there's also cases where perio is okay. So not all cases are the same, but maybe patient, there's a lot of patients with the bad situation. So if you consider that in the future, it will be good. So for you, you would put it more on the center side. Yes, on that part, it might be angle of the photo, but buccal side, I would lean more. Yes, and as you said, regenerated bone quality being bad, and leaning toward that, I do agree to that. But Austin's drills are so good, so if you put position center very well, you will not be pushed that much, and play position very well. So buckle leaning, palatal leaning, I do also have a lot of cases, but I try to keep it at center as much possible. But you do it intentionally because you want to use a residual bone as much as possible, right? Well, if I had gone back, I would do more maxillary sinus lifting. I thought I went too deep, but after I finished the case, under surgery, I thought it was too deep, but after the case was finished, I didn't have to go that much on the buccal side. That's my opinion now. So analysis is very important. So afterward, you see things a bit differently, right? So ultimately, as Dr. Park said, host bones is important to leverage, but as Professor Yang has said, host factor or a hygiene status, adjacent teeth, if it's problems, then in that case, it would have unfavorable result. So for me, that case, I would go a bit deep and put it also more on the central side, because leaning more on the buccal side is a bit burdensome. So I do have a question too. Now, for some patient, number 16, 17, 26, 27, palatal root or plate is missing due to the problems, then endo and palatal root, you amputate them and wait, then maybe palatal bone not filled after waiting for a long time. Let me answer that question. Of course it's filled, but palatal bone, if you only cut that out, then from that on, that function of that tooth, it will be lost a lot. MB root and DB root amputation, it's different levels, and if you cut it a bit wrongly, then there could be a lot of plaque. So palatal side, I don't cut it that much. Then you have treatment that is not satisfactory. So plaque there, I might have been done wrong, but what do you do? Palatal root amputation. Palatal root, I don't really cut it that much because, again, of course, there's a GBR and there's healing. But what Dr. Park said is correct. Palatal root, there's it's really wide, right? Palatal is really wide. And the functional cusp loading part, if you cut it, how functioning would be about the tooth? There's a question, so I would just extract the tooth. Thank you for that answer. So for this case, thank you for various input. So again, going back to today's case, let's summarize your answers. Dr. Kim? Well, as I said in the beginning, I would not, worry much, go deep, and if necessary, palate and bone grafting. So the case said on the buccal side, I think the doctor has done GBR, so I think there will be not much of a problem. And Dr. Park? Well, I have one more question to Professor Yang because I'm curious. So in that case, you don't lean buccally? No, yes, I would not lean buccally. So let me show you one more. Now, I leaned more on the I would lean more on the buccal side, but you would do center and do more bone grafting. For me, just looking at the photo, with the CT view, you cannot know. on the oral side, central groove linking and try to align to that line. So that position could be that position, or it could be more palatal side. I would not know. With that just photo, whether it's leaning toward vocally or not, I would not know. So let me ask again. Center position. Palatally, if it's more on 1 millimeters, then you would do that like that? Yes. If it's missing from the center, then yes, that's your principle. Again, it's not about what is correct and wrong. So you have done that in your clinic, then that's your principle. But as much as possible, maybe I like GBR too much, but I would just do GBR if that's there. So I don't really think much about those cases. Thank you very much. Then lastly, Professor Yang, please. If for this case, putting on the center, as I think Dr. Park's slide is very important. Now their soft tissue is that thick on the palatal side. That needs to be treated, handled, so that in maintaining volume, whether you do GBL later is important. You only think about position, but on the palate side, I showed you my cases and soft tissue was thick, and I briefly mentioned that that could become lower. So there you have to thin. So secure space for GBR is very important. So maybe we've been too much focused about leaning where and positioning where, rather than then cutting soft tissue to secure space for GBR, I believe is very important. So for that case, that point should be considered to have favorable results. Thank you very much. So let me summarize. Bone grafts. Don't think it too as a difficult. There are different ways of doing bone grafting. If possible, maybe placing deep could be an option, or using residual bone as much as possible would be also good. And when you do GBR, the palatal side soft tissue management is also important. I think that would be the summary. So today we looked at how to do bone grafting if there is a bone missing on the palatal side. I hope what we had discussed would be of help to you. And again, thank you, three doctors, for your good discussion. Thank you very much. See you next time.
감사합니다. 수고하셨습니다. 수고하셨습니다. 네.